No, thank you. I'm really glad we took that break and got a little feedback. We don't have an opportunity to do that very often, and I think a lot of good thoughts shared, and it's clear that you guys have a thoughtful approach to this. You know, I think it is important to keep in mind that there are more than one philosophical principle to, you know, dealing with the sort of resource allocation, and, you know, whether it's a decision that doesn't have a lot of gravity or whether it's one that, you know, is as complex as a ventilator, we need to make sure that we're thinking about things carefully. Now it seems like this mic is dropping out a little bit too, and I apologize for that, but please let us know if you're having trouble hearing us. Let's see if we can get our slides to advance here. So with that sort of initial discussion, I'm going to move in and go through for the next hour and just kind of talk a little bit about some of the crisis standards of care principles. And there we go. But first, I, John Hick, do solemnly swear that I have no financial interest, arrangements, or affiliation. So no conflicts of interest, nothing to disclose except that right now my biggest financial issue is my 12-year-old daughter. And I don't have anything conflicting that is going to cause me to have trouble with today's presentation as far as inherent bias. So what I'll try to do over the next hour here is give you a little bit of an update on crisis care and kind of where we've come from and where we're going. So when we look at our metro area, and we're actually fairly large, we're about 2.5 million. So just take these numbers with a little bit of a grain of salt, but just think about proportionally, you know, a lot of the same things apply to you all because it's very much in Region 9, it's very much sort of a hub and spoke, that we have sort of a central metro area, and then we've got a lot of other more rural areas. So when we look at our availability of resources, we do have, you know, a fair number of hospital beds. With our surge plans, we can surge up our ICU beds, our PICU beds quite readily, but we always do have, you know, caps, and certainly as we push those numbers up, we're looking more towards the crisis care rather than just contingency, that there's more risk to the patients as we go. But ventilators are a hard stop. I mean, you can't just create more ventilators. And for any of you that have tried to handbag anybody for a long period of time, my wife and I had to take 2-hour shifts bagging a kid in, you know, in one of the Caribbean islands one time, just overnight, and it's a very, very difficult thing to do. And also, you can't handbag somebody who has very complex lung physiology. It just doesn't work very well. So ventilators are very, very difficult. There's not a lot available in the leasing systems. We do have a number available in the Strategic National Stockpile, but if the whole country needs them, that's a problem. Do any facilities here in town, does Providence or others do ECMO? Okay. So as you know, I mean, that's not something that you can just, you know, put as many people on ECMO as you want to. And that's, you know, that is definitely a resource that as we do salvage therapy, venous ECMO for respiratory failure cases that are not responding to usual ventilation, that's going to be a resource that I think more and more is going to have some of the same issues. So when we did some modeling for my hospital and sort of said, okay, of all the people that are going to get influenza in our community, and what does that really mean to us? So over the peak of that weeks 4 to 7 in your bell-shaped curve of the pandemic, we'd have a case presenting that would need to be on a ventilator every 1.4 days. So if I put somebody on a ventilator for pandemic influenza or for SARS or for you know, acute respiratory distress syndrome, what's the average length of time they will spend on that vent? Just take a guess. So 4 days, anybody else? So 10 days is about average. And so when we looked at like SARS in Toronto, it was like 10.3 days or something like that. So I mean, clearly not 1.4 days. You know, we're going to be in a situation where we're going to have to make some kind of tough decisions, you know, and maybe we'll have some ventilators that we'll be able to bring in. That's possible, but you know, we can't rely on that. And again, this is an extreme example, but we realized that we were going to have a big problem that we really didn't have any good solutions to. We also realized we were going to have a major problem in the emergency department. We average about 320 visits a day in my ED, and we would be adding an additional 209 visits onto that if we were limiting the ER visits to 10 people in the ER for every one that had to be hospitalized. And that's where our public messaging, our telemedicine, everything else comes into play so much, because we've got to keep people out of the healthcare system that don't need to be there. And that's going to involve some kind of rethinking about, again, who do you tell to come to the hospital? So we actually created a framework, and it was interesting because Mike Christian was kind of doing the same thing in Canada, unbeknownst to us. And we both published our articles at about the same time, and both came to exactly the same conclusions, essentially, or very, very close to the same conclusions, which was really, really interesting. AHRQ that same year published a monograph on mass medical care in the setting of scarce resources, and so that really has gotten a lot of the good conversations started. And when we first submitted this paper to CHEST, they rejected it. In fact, it got rejected by 3 journals, but CHEST's main issue with it was that we hadn't prospectively validated it. And it's like, okay, seriously, so you wanted me to go to my institutional review board and say, I want to take people off ventilators based on their SOFA score, and then we'll give that to somebody else, and we'll see how that works out. That's not the kind of thing that's going to get through the IRB. So I don't think they really got what we were talking about very well. In 2007, Asha Devereaux and myself and Jeff Dittker and others put together a series of articles. They've been updated now as of last year. They're well worth looking at for intensive care unit surge planning, which I think is where we need to do a lot more work in general than has been done. In 2009, anticipating or basically after the spring round of H1N1, the IOM was asked to generate a report on crisis standards of care, and so that was released, and then it was updated in 2012. And this really is more the definitive work. The problem with the definitive work is that it looks really long, and people don't want to read it because it looks really intimidating. But what I would say is that within those sections, the hospital section, if you haven't done much work with this, or even if you have, if you go to the template at the end of the section, it basically will give you tasks that say, have you done this, have you done this? And if you have, that's great, you're done. If you haven't, it'll tell you where to go in the document for further guidance. And so it's, I think, a really helpful guidebook that gets underutilized just because people look at it up on the shelf or look at it on the web and go, wow, that's a lot of pages. So I don't expect people to sit around, reading the, CSC, handbooks and getting in depth in all these areas. But if you do use that sort of template framework, it can be really helpful to hone in on areas where you don't have a lot of planning in place, or there's not a lot of clarity. So the first thing is that I think we've got to be careful. There's a lot of tendency out there to say, well, these are tough questions. These are really hard discussions, so we're just not going to have them. And that's clearly not acceptable. Tenet Healthcare settled a multi-million-dollar lawsuit in the aftermath of Hurricane Katrina for failure to plan. Basically, if you can anticipate a scenario, then you have to plan for that. We owe that to ourselves, we owe that to the community, and we owe it to the providers. Because as we saw what transpired after Hurricane Katrina, in hospitals that had poor information and poor administrative processes, if you leave decisions to a clinician who is exhausted and an individual who's making an ad hoc decision, you're not going to get good decisions, and you're not going to make them with the administrative support of the institution. Those things need to happen, so there's a duty to plan. So crisis standards of care, and I talk about this a little bit more on the standpoint of crisis care, because for me the standard of care is what I can deliver at the time. And sometimes all I can deliver is crisis care, but I can't wait for the state to say, crisis standards of care are now in effect. They're going to be in effect at my institution. I just have to reach out and make sure that everybody else knows that we're in this boat and try to get some additional resources in if we can, or at least get some relaxation of regulatory standards, those sorts of things, liability protections if they're available to facilitate that. So what we're doing is making a substantial change in healthcare operations and the level of care that we can deliver to make that more of a community-based thing. That it's not about the individual anymore, it's about how can we use these resources best to support the community. At the state level and at the government level, we want to make sure that when that happens, that we're trying to provide the legal and regulatory support for those efforts. Whether that is invoking additional liability protections, whether that is assisting with 1135 waivers from Medicare and Medicaid services that allow you to do things differently, whether that is relaxing EMS regulations on how many EMT providers you need on an ambulance, or what constitutes an ambulance, or can ambulances transport people to places other than hospitals. All those are the kind of legal and regulatory powers that the state may have in order to make things better for you and allow you to do what you need to do during an event like this. Because we're all trying to do the greatest good for the greatest number of persons we can based on the resources available. It's not about meeting the individual needs anymore as it is about how do we meet the community's needs best. And that's not something that we're really, doing a lot of thinking about on a daily basis. But that's where coalitions and the whole of community response becomes super, super important. Day to day, you have, a major multi-casualty crash on the freeway. You handle it, things are good, we get a lot of feedback. Well, we do this pretty frequently, we haven't really needed coalitions before. Why do we need them now? Well, when you've got resource problems, resource shortfalls, that's when you really need them, because we've got to either bring the resources in or send those patients somewhere else or triage resources. And if you don't have a framework for doing that regionally, big problems are going to happen. And we've seen it, unfortunately. We've seen hospitals who are having to triage people that they won't put on ECMO, for example, and they call the federal government, their federal government representatives, and say, we need help. And it's like, okay, have you talked to the hospital literally a block away? Oh, no, we haven't done that. Okay, well, that's your starting point, because they provide ECMO services as well, and so you should definitely start with them. So there's a lot of situations in which triage gets performed, and some of those are in a structured way, and some of them are in a fairly unstructured way. So when we do proactive triage, that's when we've got some time to kind of think about things and categorize people when we're in an area of relative safety. I don't know if you could say the Louis Armstrong Airport was an area of relative safety after Katrina, but it was better than certain areas. One of the key things that I want to get across here too is that just because you make a triage decision doesn't mean that's the way it's going to stay. So when the disaster medical assistance team first arrived at Louis Armstrong Airport, they categorized 27 patients as black tag or expectant, that were just going to receive comfort care, but they just didn't have the resources to support those folks. Of those 27 black tags, how many do you think died? 6 of them, okay? Because as they got more resources in, over time they were able to support those folks more and go back and re-triage them. So we've got to be really careful, because we've seen in Haiti, we've seen after Katrina, that just because you tag somebody as expectant or you don't give them a ventilator, it doesn't mean they're not going to survive. They may actually outwit you and survive, which is fine, and then you have to recalculate things. There's also situations like if you're in the hospital in Joplin, Missouri, that gets hit by the tornado, and you've got gas leaks and water leaks and live electrical and all sorts of stuff, all sorts of immediate threats. You don't have time to put any proactive stuff into place. You just have to react to that, get people out, get them to safety, do what you need to do. Some great accounts of the emergency medicine that was practiced, in the ER in Joplin right after the tornado hit. Some really, great ad hoc decision making. Not going to take that away from anybody, but this is where if people say, well, I'm never going to invoke crisis standards of care until the state tells me I have to, of course you're going to have to. I mean, if you get hit by the tornado, you're in a crisis right now, and you're going to have to do something about it. By the way, that hospital was only 94.5% destroyed. Do you know why? Because 95% is the threshold for full reimbursement from FEMA. So that's what the structural engineers assessed, for the feds, that it was only 94.5% destroyed. Even though it shifted off its foundation by several feet, they arbitrated that, and it was declared a total loss, but I thought that was interesting. So when we talk about triage, the couple things to keep in mind is that, first, when we think about triage, we usually think about primary triage. So EMS responds, or somebody walks into the emergency department, and we're going to assign them a color or assign them a number and say, this is kind of your priority for access. That's primary triage. Secondary triage is when we do a little bit more assessment, a little more stabilization, and say, okay, which of these patients that has these stab wounds is going to go to the operating room first? And then tertiary triage is when we get those people to the operating room and we're pouring blood into them and they're not responding to it, and we're running out of those resources, and we say, okay, we can't keep doing this. We can't afford to keep pouring these resources into this person because we've got too many other competing needs. So tertiary triage does not get done often, and that's the area where crisis standards of care often has to concentrate its decision making. So there's a lot of goals to triage. If we're talking about battlefield triage, the main goal there is to get as many soldiers back to the fight as possible. It's not about saving the most lives, it's about getting people back to duty. But it might be about just access or priority like we do in the ER all the time. It might be about functional recovery. So there's a whole host of goals for triage. And then treatment factors. Sometimes it's the amount of time that we have to put into that treatment. If I have somebody that comes in who's in flash pulmonary edema and I know I can get them off the ventilator by tomorrow morning. If they're coming in with trauma and I've got to intubate them to get them to the operating room, but we can get them extubated after that. Time factors can be really important when making these decisions. Treater factors, do I have enough personnel to run ECMO? Do I have enough expertise to run this number of ventilators? If it's a situation where I don't have the right expertise, or that expertise is needed across many, many patients, that's going to be an important consideration. And then treatment. How many tourniquets do I have? How many of X do I have, whether it's ventilators or antivirals or whatever. So time treater treatment is a construct that I think is really helpful, and that the military has used quite a bit to analyze sort of what are the most efficient things to do for life-saving. Can you guys think of what's probably the most efficient use of time for life-saving? This is the military, remember again. Tourniquets, exactly. So that from a time treater treatment standpoint, the most effective time-invested life-saving technique is tourniquet application. So again, if you have thousands of victims, your priority is on doing things like that involve a really nominal investment of resources to save the most lives. And then host factors. When we are talking about triage, and the comment was brought up, there's, if you look at a room full of 70-year-olds, you're going to see a very diverse spectrum about how active those folks are, what their underlying disease states are, their underlying organ function, and it's important to make sure that that is taken into account. So we mentioned a couple different incident triage situations. That reactive situation where it's early on in the incident, very dynamic situation. You don't know how many victims are coming in. You may not even know exactly what happened at this point, and you're going to have to trust your clinical providers to make some ad hoc decisions. But you want them to be well educated. You want them to have an ethical framework for making those triage decisions. And just like was brought up earlier, we need to sometimes think about things that are a little different than just utilitarian. Because we might be in that situation where we have to make a little more complex decisions there. But as soon as we can, we want to try to get onto proactive triage, which is, as we get into an event that's going to last long enough, we want to get some guidance out. We want to take a consistent approach so that one hospital is not doing things completely different than another, or one provider in a department is doing things very differently than another provider in that department. So to the degree that we can structure this and provide administrative support for it and provide state support for it and get guidelines out, and so during a pandemic or an epidemic, this is particularly true, it's really important to have this. Same thing for treatment of certain bioterrorism agents. The CDC came out with a really nice article on treatment of mass numbers of anthrax patients here last year, and they're doing the same thing with botulism this year. So there are some guidelines out there. So let's just go through a couple reactive and proactive triage decisions. So let's say that bomb goes off on a bus, and I'm working in the ER, and these two victims come in. There's a 32-year-old who's got shrapnel injury, he's got a low blood pressure, but otherwise things are good. 35-year-old also coming in the next bed. He was thrown by the blast, he's in a coma, not responding really to much of anything. Also has a low blood pressure, had a collapsed lung, but we put a chest tube in, re-expanded it, not responding to it. So in a normal level 2 or level 1 trauma center, who's going to the OR in this case? So most likely, we're going to be able to get both these people to the OR at some point. But generally speaking, this person who's got an isolated abdominal injury and is hypotensive is going to have a simpler operation, and they've got a better chance of a good outcome than the person who's in a coma. But generally speaking, if we've only got 10 patients, we'll probably be able to get both of these folks to the OR pretty quickly. But let's say that you've got a large-scale explosion, and you've got now 100 patients, of which you've got these two. Does your decision-making change? Do these two patients still have equal priority for the operating room or not? So in this case now with 100 patients, you're really going to be lucky to get this person to the operating room. But if you can get in there and get that, whatever is bleeding fixed, whether it's a spleen bleed or something like that, quickly, which you likely can, hopefully that's no more than a, half-hour, 45-minute process, and you don't do a formal closure, you just basically do a temporary closure and get them out of the operating room. You can save that person's life. But let's say it's a really bad day in Spokane. And I think this would be a really, really unusual circumstance to, have a nuke det incident in, an area anywhere besides, New York, LA, a few other places. But still, if you got 1,000 patients, who's going to the OR? Nobody. Okay. You're not going to invest that kind of time and resources when you've got that many patients, and what you should be doing is putting on tourniquets and just basically doing basic opening of airways, saving those moderately injured patients, and not expending the resources on people who are going to consume too many resources that could have been used to save others. So this is where we need to kind of make that shift to a less individual basis. Now, proactive triage, and I apologize because I noticed that I left in ventilator down here, and I'm talking about ECMO up above, so you can use either one. But patient 1 is a 6-year-old who's on ECMO or on a ventilator for respiratory failure from influenza. SOFA score is 8, that's an intermediate prognosis, good underlying health. Patient 2, 15-year-old who's not on a ventilator but failing on the vent, good underlying health. Anybody going to take that 6-year-old off the ventilator to put the 15-year-old on? Probably not. What if that first patient is 60 years old? And now you've got a healthy 15-year-old who needs a ventilator. If I show of hands, anybody willing to make that switch? We got one here, a couple. Yeah, I would. I mean, I think that's, SOFA and 8, SOFA 7, fairly comparable, but from a life cycle standpoint, not necessarily just a survival standpoint, that 15-year-old, I would give at least some consideration to that. I would want, though, the community to be telling me that that's the right thing to do, because I don't want to be making choices based on age and cultural norms when that's not backed up by the community. Don't put cultural decisions and social decisions on the backs of the medical providers, because just medically speaking, the outcome here is probably the same. So, question?
Would there be any difference in terms of how people look at that if it wasn't, taking the person off of ECMO or off of the ventilator, and you just have those two patients presenting at the same time?
Great. Yeah, great question. So what if this person was not already on the resource? What if they just both showed up in the emergency department at the same time? And I think no question, that's seen as a difference, and a lot of people would say, oh yeah, in that case, if they both just came into the ER, I would give it to the 15-year-old. So I'm going to turn to my ethicist. Is there a actual ethical difference between putting somebody on a resource and taking off?
So ethically, there's no difference between withholding and withdrawing.
Yep.
However, we were just talking briefly, there's the most recent time we put an adult on ECMO, period, rather than a pediatric patient, was not too long ago from influenza in their 30s. And there was, I'd be really surprised if we put a 6-year-old on ECMO to begin with.
Yeah. Too true. And I think you could think about this as what if they were just on a ventilator. But I think there's, people need to understand that when we talk medically about not providing support from ECMO or ventilator or taking it away, there's no ethical distinction there. But if you talk to the general public, there's a huge difference mentally between taking something away from somebody and offering it in the first place. So it feels different. And it feels different to providers too. So again, let's say that the 6-year-old that was on ECMO or on a ventilator had advanced cystic fibrosis. Very severe cystic fibrosis was going to be significantly life-limiting for that patient. And now you have a 15-year-old that needs that resource. Anybody going to make that switch? Got at least several that would consider it or think about it. And I agree. I mean, I think when you've got someone who is one, likely to be on that resource a lot longer and likely to have a very foreshortened life. You would have some good grounds to make a decision to put that 15-year-old on. So what if you had a 6-year-old that was, day 4 on either ECMO or ventilator and has SOFA at 13, which is predictive of in excess of 90% chance of death. And now you have a 15-year-old who's otherwise healthy coming in with a SOFA score that would predict, maybe a 30% chance of death. Who's going to make that switch? By a show of hands. Anybody? Yep. And again, several people, thinking about, okay, that person clearly has a much worse prognosis, from an outcome or likelihood to survive standpoint than that one. We'll make that switch. So, and again, the key thing is that we should never, ever be making those kind of decisions. And that's a very extreme example of crisis care. But we should never be making those decisions when we can avoid it in isolation. So if you're a hospital that's kind of facing these decisions, you want to make sure that all the other hospitals in your coalition, your jurisdictional, all the way up to the state and the feds, if you need to, are trying to provide what support they can to get you out of that hole. So we always want to make sure that there's a common ethical framework for what we're doing. And a lot of that ground has been well trodden. There's a lot of good articles out there. The IOM report provides a good summary. You need to make sure that you're aware of what legal and liability protections exist in your area, and make sure that you understand kind of the roles at the state level, on what platform, by what mechanism you're going to coordinate regionally, and then what's the hospital role? How do we accomplish our mission? So there's usually a planning framework for, making kind of outlines of these and getting going on them, and that's different than the operational framework, which is how do we actually do business during a response, and who do we coordinate with, and how do we do that? And then finally, and I think a lot of the emphasis winds up on decision support tools, like do we use the SOFA score, et cetera. I'm much, much less concerned about that than I am about the process. I want to make sure there's processes in place at every institution, in every region, for when things get bad, how are we going to solve those problems? And you can adopt a number of different strategies. You can prepare by stockpiling stuff. You can substitute, one drug for another. You can adapt. You could use, an anesthesia machine for a ventilator. You can conserve resources. So, for instance, not using oxygen as aggressively for patients as we might normally. You can reuse stuff. A whole host of medical supplies can get reused. It's just that very few manufacturers actually go through the trouble of licensing for reuse, because why would they do that when they can sell more? And then reallocation is kind of the last thing that we would want to do. That's to actually, take something from someone and give it to someone else. So who can think of an example of things that are in shortage that we're having to do some of these strategies with each day in the hospital? Drugs, absolutely. Drug shortages are kind of a bane of my existence these days, because it tends to affect a lot of the medications we use in the emergency department and other places, and especially in oncology. And so ASTO came out actually with a recommendation that healthcare facilities consider using the crisis care framework for dealing with drug shortages. It gives you a chance to formally practice with those systems, make sure clinicians are engaged in the process, provide some structure to that, and that can work really, really well to get institutions thinking about these frameworks and how they might use them, during a disaster, if they're already using them on a fairly routine basis for sort of daily disasters that are occurring in our pharmacies. And you can map these strategies across, conventional contingency and crisis frameworks. So, depending on what you're doing, there's going to be either a certain amount of risk to the patient or not. It doesn't risk the patient at all, if we titrate oxygen flow rates or if we substitute equivalent medications. There's a little bit of risk when we start, doing things a little more aggressively, reallocating O2 sat monitors and cardiac monitors. And there's, fairly substantial risk, but risks that we have to take, when we get to the point of really running out of resources and having to do things like re-sterilize central lines, for example, or, sort of the ultimate thing, reallocate ventilators, which again, I think gets a lot of discussion time, but is not one of the things that I want people to spend a lot of time on. So I get this like every week, this is just the first page of the drug shortages that occur at my institution, prioritized by red, yellow, and green, depending on their effect on patient care. But it's pretty crazy how many hospitals, when you survey them, we're talking 82% having to delay really important medical treatment to patients or not being able to comply with recommended treatments. And in oncology, this can be incredibly difficult because a lot of the usual drugs are injectable and they're generic, which means very few manufacturers are making them. And when you have any hiccup in the supply chain or the manufacturing process, all of a sudden, you don't have the most appropriate drug therapy for a lot of cancer patients. So up to 70% of hospitals reporting patients got less effective therapies because the most effective drug wasn't available. And then saline. I mean, who would have thought that we'd have a shortage on saline? And yet, there we were, and we were literally, instituting pre-op orders that maintained people hydrating orally until 4 hours before their surgery instead of being NPO after midnight. A whole host of things that needed to be done, to cope with that. So if we can, run out of salt water, we can run out of pretty much everything. So again, how many folks have seen this continuum of disaster care? So this is what I think is, if you take nothing else away today, I think this is the thing that I want you to remember, is that when we talk about surge capacity, which all of us need to be planning for, whether we work in home care, in the emergency department, wherever, we need to make sure that we're thinking about how do we expand our capabilities. And conventional is easy. We sort of fill up our usual beds and usual spaces, but there's not a whole lot of that extra space laying around. There's not a lot of extra staff laying around. So doing our planning to increase this contingency space where we provide functionally equivalent care. So if I put a patient who should be in the surgical intensive care unit in post-anesthesia care, for example, and we have to keep them there for a while, we can provide functionally equivalent care, but there's going to be a lot of things that go into making sure that the electronic health record is appropriate for that setting, and that the staff are trained to provide some of that care there. There's just some things that we need to do to make sure that's safe. Because the bigger this yellow zone is, the better off it is for our institution or for the community. We don't want to wind up here, where we're really putting our patients at risk because we have to make more community-based decisions instead of making individual patient decisions. And this is a seamless framework. Nobody should be developing a crisis standards of care plan that's like separate from their emergency plan and sits on a shelf and only gets the dust blown off it once every 55 years. You need to have an expansion plan that kind of expands and contracts through these with the goal that you get yourself back to conventional as quickly as possible. So when do you know you're in it? Indicators and triggers can be pretty important because you want to make sure that you anticipate things going bad, and some of that is pretty easy when you've got epidemics. Maybe you've got a tornado watch, maybe there's a flash flood watch, so certain indicators can tell you that maybe you ought to take some actions to prepare for things. And then trigger events occur, like all of a sudden we don't have any more ventilators. Well, now what? You'd like not to get to those points, but you want to make sure there's actions to be taken when you do hit those. And using incident management is key. If you're not using an incident action planning process, if you don't have clear lines of authority, if the administration is not taking responsibility and maintaining accountability for the decisions, bad things are going to happen. And bad things happen too when administration doesn't get clinical input. And that's not just true in disasters, of course, but you want to make sure there's a mechanism for getting clinical input, for getting the docs to provide some input into the decisions that get made. And that's really one of the key things that's a little different with crisis care than it is with regular care, because those triage processes that are occurring really need some thoughtful medical input, and you might have to get kind of a poll of clinicians in that case to get some of that. Communications, not just within the hospital, but to the public. I think somebody mentioned about managing expectations with the public. That's huge. If you come into the hospital and we put your mom on a ventilator and don't say anything, that's a lot different than saying, your mom's really sick, the situation we're in, we're not sure that she's going to be able to stay on a ventilator. We're going to give her one for now, but just to tell you, here's our policies. If someone else comes in, that really needs that, we're going to have to give it to them. But for now, we're going to be able to offer it. That conversation feels a lot different than just saying, we're taking your mom's ventilator away. Triage decisions and processes, again, it's the process for me that's really important, not as much the guidelines. And then, I think there's a tendency to say, well, okay, that decision's done and we're moving on. But especially when we're making proactive decisions, we want to keep looking at the evidence and saying, is there anything else that can help us here? So as we get into a pandemic, if we find out that left-handed people survive this pandemic strain much better than right-handed people, that's really important information, and we need to go back and incorporate those things as we find them out. But the goal is to try to get back to that conventional status as quickly as we can. If folks haven't seen these, the Minnesota Department of Health put out some crisis care decision tools that can be helpful. They're designed for oxygen, medications, staffing, blood products, renal dialysis, whole host of different resource categories where it basically gives you some strategies that you can use. So this is one of the cards for mechanical ventilation and ECMO that just walks you through a decision process that can help you to make some of the decisions on whether or not you need to reallocate resources. Again, I would much rather you concentrate on the process where these get used rather than trying to kind of rethink or think your way through these as much. I mentioned about integrated surge capacity plans. This is a table that our charge nurse, our nursing supervisor for the hospital has on their clipboard with them all the time, which basically just shows by time and by green, yellow, red, by conventional contingency or crisis, if we need to expand space rapidly, what do we do? Which rooms can we use? Where do we overflow to? And the ICUs have a similar grid. And ICU expansion is probably the toughest nut to crack. And so the CHEST guidelines that just came out recommend that you can get up to 20% surge within hours, that you'll be able to double your ICU capacity within a couple days, and that over 3 to 5 days that you can increase your capacity by 200%. And you don't necessarily have to have the resources in-house to do that. We don't expect that. But you have to know where you could put those patients so that if we do get you the ventilators or get you the monitors that you need, that you could provide that care. So just having that plan mapped out, knowing what you would do and where you would put people is really important, because as people get sicker and sicker in the community, then the level of acuity needs to go higher and higher in the hospital. So on a daily basis, our ICU capacity often is about 10 to 20% of the general hospital capacity. But in a pandemic or in a really bad disaster situation in the community, that acuity increases dramatically. And so we've got to figure out how we dramatically expand that ICU capacity and where we push those other folks to. Are there long-term care options, home care, cot-based care, even alternate care sites that might need to get set up. And you might need oxygen, you might need other things at those alternate care sites. So kind of figuring out some of that overflow and how we would really concentrate that ICU care in the hospitals. And that's where the coalitions really shine, because in multi-agency coordination with public health, emergency management, and EMS, we can make a lot of those things happen. And it's so critical that we're working hand in hand with public health and with emergency management and with the Joint Information Center or our local media to get the right messages out there. Because if the message is, flu's really dangerous, so if you have any flu symptoms, you should go to the ER right away. That's not exactly a message we want to get out. It was just like when we had the bridge collapse in 2007, one of the local TV stations had this banner going across the bottom. If you want to assist, please go to your local hospital to give blood. Well, okay, we had 54 patients that have been transported from that incident, and the only blood donations that happen in my hospital are involuntary because somebody's bleeding out from something. We don't take any blood donations. Those all go through Memorial Blood Center, and they don't collect off hours. So that's the kind of media message that unfortunately winds up making things worse for us and consuming more resources and potentially pushing us into crisis care faster than if we had really effective messaging and we were able to kind of manage those community interventions, telemedicine, other opportunities to connect with people. And at the EMS level, we also need to be thinking about this, because I think there's a tendency for EMS to say, well, this isn't really my thing. We'll transport the patients and we'll get them to the hospital and then you guys can figure it out. When in truth, in most rural areas, EMS is probably the weakest link in the chain. You're lucky to staff one ambulance with volunteers on a routine basis. And so, when that public safety answering point, when that sheriff's dispatcher picks the phone up and somebody says, I need an ambulance, and you don't have any mutual aid within 40 minutes, then what? Do you have some numbers you can call for rotor wing. Do you have any other first responders you can send? You know, what's your decision tree? Because we got to figure out, you know, how we're going to manage those assets too. And sometimes, you know, in smaller communities, that can be the biggest limitation. So Hennepin County actually developed some tools for those answering points that didn't have medical dispatch to kind of walk through and say, do I really, really need to send an ambulance to this address? You know, do they have alternate transport? Do they have any life-threatening symptoms? You know, if not, sorry. We also gave our paramedics a lot more leeway, and so we can enact these crisis plans at any time. We give them a lot more leeway to leave people at the scene. If the medics get out there and say, this person does not need to go to the ER, we know what conditions are like in the ER right now and it's not appropriate, then they can leave them. So we give them, they've got a couple pages of directives there that they can follow. And at the hospital level, we do have our Metropolitan Hospital Compact has a scarce resource plan that just basically runs through quickly the foundational elements, basically referring out to the IOM and other work. Includes some definitions for when we would invoke that plan, whether it's an isolated circumstance, because we've had a number of circumstances where one hospital has run out of vents, or one hospital has run out of prone position beds or other things, and we've had to put out an appeal to other hospitals to say, can you either take this patient and transfer, or can you supply this resource? And it's worked out fine. That's not a scarce resource ongoing situation, in which case we would ramp up more of a framework to say, okay, we've got to do some more system monitoring, we've got to create some solutions here. So if it's not isolated, the Regional Hospital Resource Center, you know, will basically do some alerts and notifications, we'll poll the hospitals about available resources, notify the state. We don't have a regional medical advisory team. We do have regional medical advisors that can provide medical input early on. If we need to get other folks together to get engaged on that, we can. The state does have the Science Advisory Team, or SAT team, that provides that function for the state level. In most cases, there's not a role to have a really large, you know, regional medical advisory team, but it does make sense sometimes in large metropolitan areas. So the, you know, King County, Harris County, the Houston area, and Dallas, because they've got such a large concentration of different facilities, it can make sense there. But in most areas, you don't have to have a separate team, but you do need to make sure that there's a way to get clinical input into the process. And then any requests that go up to the state or go up to the feds, it details how the region would coordinate that with emergency management, and then it talks about a regional framework for triage. Because it's important for us as a referral hub that if we have a patient who is coming into a smaller hospital in the outstate and really needs a ventilator and deserves one based on the other folks that are, you know, in the hospitals in the metro area, we don't want them having to call 20 hospitals. And so basically we create a gatekeeper situation where they can make, you know, one call and get some information, and we'll figure things out. So just a quick question. Let's say that you know, in your intensive care unit right now, you've got a handful of patients that are really, really sick and not likely to survive. So as that first wave of pandemic victims comes in over the course of the first few weeks, you may make some pretty hard choices about who gets, you know, those resources. As that pandemic goes on, are you going to be faced with as many choices? No, why? Well, you've moved through the, so, and the answer was no, you've moved through the peak of the wave. And the other thing is, you've already exchanged out the sickest of the sick and put a lot younger, healthier, whatever, patients on those resources. So now, you don't have as many choices to make, because nobody who's walking through the door is going to have a clear-cut indication to take that resource from somebody else and give it to them. So the good news is that triage process, you may have a lot of decisions to make early on, but as the event goes on, you're not going to have as many really tough decisions, because the people that wind up with the resources are going to be younger and healthier as the time goes. And then you pass that peak and you're on the downslope, which is good. So we talked a little bit about this earlier. It's very appropriate to consider likelihood of benefit, change in quality of life of the intervention, the duration of the benefit. Urgency of need is not as important when it comes to ventilators, because everybody needs one now, but you know, with other therapies that can be an issue, dialysis for example. And then the amount of resources required, we talked about that time treat or treatment. but we don't want to be considering things that we should not be taking into account, and that could be patient's contribution to the illness, past resource use, those things. Social worth, this is from the AMA, and that's really more about somebody who isn't perceived to have as much worth in the system. It's not about instrumental value in the response. That's different, but that's not a primary thing to think about with a patient. That's more of a societal thing that needs to be decided. So again, don't lay a non-clinical decision like that on the backs of a clinician. Make sure your community is giving you some input to say, yes, we think healthcare providers should get some priority, because if I as a healthcare provider decide I'm going to give myself priority, that doesn't look very good. Age is an interesting thing, because among certain cultural groups, and you all have a significant tribal presence here, as do we, the elders are actually much more venerated. And so in the Hmong population, our Native American population, what we've heard is we want the elders prioritized for resources, because that's the glue that holds the communities together. And so it's very important to make sure that we're taking a broad look at not just what's the 80%, but are there cultural groups that have very different desires and expectations. And then if we're going to say, yes, essential personnel will be prioritized for resources, let's be clear about which ones and who the essential personnel are. So at the hospital level, having a crisis care plan where you've got a trigger, you've got notifications to your administration as well as key chief medical officer and other folks, you're integrating this into incident command system. And again, this is not a separate plan. This is just as the incident evolves, if things are getting worse, we'll invoke this as part of ICS, but who participates, what are the decision tools we're going to use, and then how are we going to communicate these changes out, to both our clients as well as our workers. Anytime we're going to do something like this is going to be an extremely hard situation for everyone, and especially for the families and the providers that are directly affected. So we've got to be really proactive about making sure that our behavioral health, our mental health support is as best as we can provide. And there's going to be some prolonged follow-up, a long tail on these events that's going to need attention. There may be security considerations too. If we really have to, give medication out only to certain individuals, if those medications are getting moved around, there are going to be security considerations. If we're having to withdraw life support, there may be security considerations. There's huge public expectation management issues here. There's also a thing about documenting your decisions. It's got to be really clear in the medical record what process you were following when you made certain decisions, whether that's prescribing Tamiflu or whether that has to do with ICU level care. We've got to make sure that there is a structure for doing that. So you may want to create one in your electronic health record, and then those decisions need to get audited. If it is really a clear-cut resource allocation, triage decision making, then we need to audit that and make sure that's being followed, and that the CEO's daughter didn't get preferential treatment when she didn't deserve it. And we can't forget about palliative care. That even if we can't provide resources, certain resources to patients, we should always make sure we're providing comfort level resources. And that's critical. We can't forget about that, because everyone deserves comfort. And the recovery from this, as I mentioned, we want to get back to conventional, but then dealing with the aftermath, within the community and within our provider workforce is going to be important, and that's going to take a long time. So some new issues. The experience in Haiti was desperate and awful, but it was really helpful in a lot of ways because it crystallized a lot of these constructs. A lot of providers who went down there really did have to make real-time decisions about, I don't have enough ventilators, and so this is what I'm going to have to do. I can't operate on all these people, and so this is what we're going to have to do. We can't bring all these people back to the United States, so here's the triage decisions we're going to make. And what we found is that the constructs in general work. And a lot of times it is individual clinicians, but they're relying on some of these constructs in a lot more structured fashion than they might have before, and it actually does help. The other thing we found out is that SOFA scores, or sequential organ failure assessment scores, don't work very well in isolated respiratory failure. And my feeling all along has been that we should never say to somebody walking in the door, based on your age and X, you're just not getting a resource. So that, and honestly, the way some of the scoring mechanisms have been, I could have a ventilator right here, and you could walk in the door and need a ventilator, and I would say no. Based on the scoring system, you don't get a ventilator. That's not a good idea. It's much better to give the resources that you have, as long as it's something like that that is life-saving and can be reused or reallocated. Go ahead and start it, and if you have to, you can withdraw that and give it to somebody else, but don't be hoarding resources, and sort of crossing people off the list because of a score that they got that may or may not be predictive of their outcome. And we've got to involve the coalitions in the state in these discussions. You do not want to be implementing these in isolation, and I know I've said that before, but I'll say it again. Cooperation and coordination is just huge here. In crisis care, we've gotten, a lot of people get really wrapped around the axle about ventilator triage, and people get all freaked out, and ethically people get freaked out, and the community gets freaked out. Stop. What I'm really asking you to do at base is make sure your surge capacity plan thinks about what you do when you get beyond contingency, and you're working off cots, and you're really stretching providers, and you're having to do just-in-time education for stuff that's out of your comfort zone. That's the area where we need to devote some planning time and make sure that there's a process in place at the hospital, at the coalition level, at the state level for when that sort of thing happens. Nobody can disagree with that, okay? I don't care what your legal or ethical or other arguments are. All of us need to have plans in place for when there isn't mutual aid, for when we're working off cots, for when we can't accommodate the volumes. You don't want to just make ad hoc decisions there. Have something in place. There's a lot of legal things that do enter into these conversations, but a lot of it is just understanding what is available within the state. And Washington has done a good job in kind of looking at their legal framework, their emergency powers, and I know there's some processes and some things in motion to try to get some additional liability protections. I think that's great, but it doesn't prevent the work from needing to be done, just in case something happens. And then community acceptance has generally been really good. When we've gone out and done the kind of community discussions that have been talked about here, we generally get pretty good buy-in on, yes, we understand the need to do this. We really emphasize we want transparency from the healthcare systems when this is happening. Don't keep this under wraps. Let us know what's going on. Provider acceptance is something that we're still working on. In some ways, sometimes this is tougher because of the commitment providers have to their patients, and so that's why we really recommend that the bedside provider not be the one making those decisions whenever possible. Sometimes you're stuck when you're in the ER, but up in the ICU, it's better to have somebody else looking at the situation. The road ahead, we really hope our prediction tools for survivability can get refined as time goes on, and as we can leverage some electronic health record data and ICU data nationally, we should be able to get things honed a little bit more. We want to make sure that we're integrating those crisis care decision processes into the drug shortages, into sort of our usual supply chain disasters that are occurring. And then getting in, looking at some of the ICU targets, and oh wow, how would we accommodate a 200% increase in ICU volume? And when we first sat down to look at that in my hospital, it was like, we can't do that. And what we realized was we can't. It's just a matter of kind of knowing exactly where we put people and what the capabilities of those areas were, but we can do it. In fact, we can get beyond that 200%. And getting that community engagement into the process so that we define those other expectations, those other values, whether it's the life phases, the fair innings effect, as Daniels refers to it. What are the things that you want me as a provider to make sure that we account for that aren't just health-related issues? And getting that provider engagement, practicing these processes, talking about these things, talking about these situations and giving examples, so when the time comes, we're more comfortable with that framework and what we need to do. So the best defense is a good offense. If you think about stuff ahead of time, you're much more likely to make the right decisions when the time comes. Focus on the legal and regulatory support for what you want to do. So let your jurisdictions, let your state know what your plans are and figure out how the legal and regulatory framework can support that. Make sure that you've got operational plans in place for that spectrum of surge capacity into crisis care, that your process is defined and that it's consistent, that you're not relying on individual institutions to do their own thing, but trying to introduce a level of coordination into that process. And that's where that coalition is so important, and you guys are already well on your way to doing a great job with that. It's really really nice to see, the degree to which Washington and other states have done implementing the coalition concept. So with that, thank you. That's a really rapid tour through CSC that I could literally talk about all day, but thank goodness I was limited to an hour. So what questions do you have?
And I'll run the microphone for you.
All right, let me just walk the microphone back to the people with some questions. Start here. And again, an introduction, name, and an agency, please.
Mary Badger, Internal Medicine, Columbia Medical Associate. I have a question as far as crisis standards of care tips for those of us that work at freestanding medical clinics that are not associated with a hospital, how we can get set up so that we're available when the need arises.
That's a great question. I'm glad you asked, because freestanding medical institutions, ambulatory care, things like that, a lot of times say, well, we don't have a role in this, and the answer is no, you absolutely have a role in this. And in fact, if we don't have really good participation, by those exact facilities, then the whole thing's going to fall apart. We had a lot of clinics early on in H1N1 say, well, we're just not going to take any of those patients. And it's like, well, if that happens, then we're all going to be in trouble. So figuring out, at the clinic level, the normal referral patterns may not be available, your normal processes may not be available. How you deal with your patient flow may be completely different. So having a plan to decrease your elective appointments, increase use of telephone or internet contacts with your patients, changing office hours, changing office entrances. So a lot of places, and you may have instituted separate entrances for H1N1 or separate waiting areas. There's a lot of things that clinics, ambulatory surgery centers, other places can put into process within their own institution to adapt to these crisis situations, and then just make sure that the way you're going to play that playbook fits with the rest of the healthcare system. That it's like, hey, these are the assumptions that we're working off of. Does this fit, with what you guys are doing? But I think it is imperative that those conversations, occur across the whole of the ambulatory care, spectrum. And there are a few examples out there that we can certainly follow up offline and we can try to help with.
So Michael Larrigan from the Department of Health. So having an ethical framework for decision making is one of the core pillars of crisis standards. And I'm sort of struggling with this concept of, I think in the Iowa guidance it suggests an ethical framework at the statewide level, the state level for making decisions. But what I find is that the ethical values from one part of the state to another may change, may be distinct. And so we have work, you mentioned work that had gone on in King County, there's work going on now in Vancouver, Washington on this. And do you feel that it's okay to have perhaps an ethical framework at the state level for advising, for example, the Secretary of Health and the State Health Officer on decisions that will be relevant for the state's book of business, but maybe a different set of ethical frameworks that reflect local values, and those frameworks might actually differ from each other? Do you think that's okay?
So it's a great question. So generally speaking, the ethical principles never vary. The principles in and of themselves, which is really nice. I mean, those you can kind of outline and you can take what the IOM has done, or you can kind of adjust that and you can say, boom, that's what we're starting with. How you apply those to the community and what the community values under some of those headings can be a little bit different and a little bit nuanced. Now, as was mentioned before, the core framework for triage that we have always used in medicine is utilitarian. And so generally speaking, nobody is going to say throw it out the window. But after you get past that point, are there cultural or local community values that we want to apply with sort of those secondary decision points? And there's where there's some subtlety that comes in. And so for the state to say, here's our overall, here's the guidelines, and here's some clinical tools that we would recommend to get you past that utilitarian, who's most likely to survive, greatest good for the greatest number sort of thing. The locals can then use some nuance in those secondary decision levels to say, does it make sense based on what we know about this individual's tribal role or other things to do things a little bit differently? So I think fortunately there's some allowance for that within the spectrum. And at the end of the day, it's not about any kind of mandate from the state that thou shalt do this. There's no stone tablets here. Ultimately, at the clinician and the hospital level, you have to be able to document why you did what you did. And if you did that according to an ethical framework that the community agrees with, and by decision tools that are generally accepted, you're going to be fine. If you chose to go off on your own and make some decisions kind of based on your own internal constructs, you could be in trouble.
Thank you.
Any other questions or thoughts to share in the room? Yes, Dr. Edminster.
So this is from an ER doc perspective, so.
Good.
Might put some other feelings, but, so I think that a lot of, when you hear lectures like this, you're saying, well, how do we'll prepare for this disaster, but disasters are few and far between, right? But my thought is that we actually have an opportunity every day to reinforce the correct behavior with our present status of overcrowding, which is a national phenomenon, diversion, which is a national problem. I suspect you have the same problems in Hennepin County with overcrowding. I don't know whether or not you have a diversion policy for EMS, but my thoughts are day-to-day improvements to solve those dilemmas of surge, which are predictable surges, as opposed to an unpredictable surge, will reinforce our ability to appropriately respond on a major disaster. So how have you addressed some of those areas locally to improve your day-to-day surge capacity problems and anticipation of a bigger event?
Yep. So perfect question, and I'm always glad to get a good ER perspective on things, as an ER doc myself. And don't worry about hurting my feelings, because I'm an ER doc and I don't have any, that. So as I tell some people who say, you just don't care, and I don't say it, but it's like, I do care, I just don't care enough. So, and which also is not true. I care a great deal. It's just that certain things I've gotten a little bit inured to. So, just because you lost your Percocet for the third time, doesn't necessarily make that my problem. So when you talk about surge capacity and kind of how we use daily practice to reinforce disaster practice, that's really important, because generally speaking, you always come back to what you know and what you do on a daily basis, and you try to apply those same constructs in a disaster. And for the most part, that can work pretty well. But if you're not kind of thinking with the right reflexes, then you can get into a little bit of trouble. So two things. One, on the diversion, from a diversion standpoint, we only allow diversion up to a certain point. You can only go on divert for like 4 hours. So you don't get a free pass to stay on divert as long as you need to. So the hospital is going to have to implement some staffing or surge plans in order to get off a divert, because automatically that clock's going to reset at 4 hours and you're open, and then you've got to stay open for 4 hours before you close again. We used to have hospitals that gamed that system a lot more, but now as their staffing and their surge plans have gotten tweaked a little better, we don't see that as much. So I think that sometimes playing with the diversion policy can help there. The other thing is that our units have gotten a lot more flexible when we have what we call an internal capacity alert, which for me is like gold, because they're having to pull those surge grids out and saying, okay, what are we going to do? And that's changing the standards that certain units, it's like, oh no, we won't take a potassium below 3. It's like, well, now you will, because I don't have any other better options, and I can't keep this person down here in the ED on a ventilator overnight when I can have that ICU bed, and you can push that patient with a lower potassium out and change your staffing ratio on that unit. So encouraging that kind of creative problem solving and reinforcing the nursing supervisor's ability to engage those surge plans and run into those when you've got capacity problems, then they're used to referring to that. Same thing with drug shortages. Early on, pharmacy was just sending out the list. But now we've got them thinking about, okay, how do we substitute? If we're going to adapt, what does P&T committee, pharmacy and therapeutics, and the clinicians say about what our first, second, and third lines are? How do we build that into the electronic health record? So getting structure around all those things that people are kind of used to on a routine basis, then when you get into a disaster and you've got an opportunity to either just apply it in the moment, you will, but then if you've got a chance to get proactive with it, you've got the time, a lot of those same structures then we're invoking and we're doing the same things. But yeah, daily practice equals disaster practice for the most part. Oh, question right here.
Can I just have you elaborate on what the structure was or how you changed the standard, so to speak? So let's say passing, for instance, or because it's great to say, you know, we're going to change our nursing ratio from 4:1 to 5:1 during surge capacity on medical floor.
Yeah.
But how do you, I can't, as an ER guy, say, I need you to do that and have the floor do that.
Yep.
I mean, what's
So,
the,
so how do you go about making those administrative changes that allow for that degree of flexibility when you want to admit a person to a unit and you don't have the right bed or there's sort of exclusionary criteria? And we had to really take that back to nursing administration and make it their problem and say, okay, from a patient safety standpoint, it makes no sense to tell me that boarding an ICU patient in the emergency department overnight on a ventilator is safe for them. So let's look at where we can make compromises. And so during daily operations, here's kind of where we are, but here's what can budge when we get down to it. Like if you've got somebody from a long-term care facility who's been on a ventilator at their long-term care, well, that's not an ICU, and yet when they come to my facility, all of a sudden they have to be in an intensive care unit bed. Well, okay, but when things get really stressed, we'll move that person to intermediate care. You know, so of the categories of things that are critically important to you nursing folks, what is non-negotiable and what is negotiable? And then let's work it from there. And sometimes when we have like electrolyte and other thresholds, you know, we can do a little tuning up, get them to a certain point, and then they're okay. But we had to get them to kind of say, this is a hard stop, and we're not doing that, versus, yes, we'll flex on this. Yes, we'll take mild diabetic ketoacidosis here. But on our normal day, we'd prefer not to. And that's where that contingency kind of comes in.